So GLP-1 analogs, the name is glucagon-like peptide. So when I went as a cardiologist that what is this drug, then I came to know that this is not working like glucagon-like. It is actually inhibiting the glucagon. And actually the name is because it has origin from the same what we call is pro-glucagon gene. So when we speak of human type of GLP-1 analogs, which is liraglutide and semaglutide, the story is that when they are used in low doses, these are anti-diabetic drugs. And when you go in higher dosages, then these are anti-obesity drug and we do see weight reduction. But we as a cardiologist do get confused because what happens is all drugs as in high doses are not launched in India and then they have different name. For example, we have Victoza as a liraglutide in India till 1.8 milligram. But the higher dose, which is 3 milligram anti-obesity drug, is named as Saxenda in USA. So it's the same drug with two different names. And same thing happens with injectable semaglutide. Injectable semaglutide till 0.51 mg is an anti-diabetic drug. But when you go in 2.4 milligram, it's an anti-obesity drug and it can be used even in non-diabetic obese patients. So this is a usual confusion because Saxenda is not available in India, higher doses not. Injectable semaglutide has not come in India and now we are directly with oral semaglutide. So the story usually is from anti-diabetic drug, first they prove a glycemic efficiency, then you have CVOTs and then they come as an anti-obesity drug. And Dr. Hajara, you have seen the evolution of this drug, how liraglutide was approved as a weight loss drug after a scale trial also. Similarly, semaglutide was approved last year, injectable once a week, as a weight reducing agent. And the indication is obesity more than 27, BMI more than 27 with one of cardiovascular risk factor. And another indication is weight more than 30 and there is no risk factor. So can anybody guess what population of USA would come under this indication of the drug? Any wild guess? 20, 40, 60, 70? So they say approximately 70% of population would be eligible because majority have one or risk factor and obese BMI more than 27. So when I looked into leader study and started to use liraglutide initially, it was difficult because majority of endocrinologists, they always say it's an injectable, it was a costly. But when I saw the mortality benefit, I started in my, what I say is cardiac patients, those are on very high doses of insulin. And it was very, you can say, life-changing experience that almost 50 to 60 units of insulin requirement of these patients goes down within a period of 3 to 4 months. And that was, and that is how I started using liraglutide over last 5 to 6 years. Now, as far as semaglutide is concerned, the current 14 milligram dose is similar to Ozempic dose. Now, oral semaglutide has taken the first step. It's an anti-diabetic dose. The pharmacokinetic level is not like what you call this Wegovy. All of us you have heard Elon Musk recently tweeted that he lost 13 kg after he took Wegovy. So that is a story of GLP-1 analog. So its predominantly effect is atherosclerosis, anti-atherosclerotic agent. So as you have seen the residual risk of atherosclerosis, these drugs takes care, which was in last presentation. So diabetic with all risk factors, this is a common patient. So how do my practice change? Injectable liraglutide was for my most complex patients. We were already taking injectable. Now with oral, the scope is increased and I could now line up with guidelines. Guidelines says after metformin, if you have predominantly ASCVD drug, this is the first line of drug. But it was not practical in majority of patients because it was injectable. Now these type of patients we do daily in your outpatient clinic, young patients with high BMI, high sugar, these hypertensive, dyslipidemic, and a family history of heart disease with high LDL. And if you calculate this risk score or Q risk score of this patient, Kausal, you find that 10-year risk is almost of 51%. Now, we all know multifactorial reduction in diabetes is helpful, and this is one of our old study. And recently, it has almost long 20-year follow-up where you have an aggressive lifestyle modification. And what you can see that if as a more aggressive control of risk factor, which is diabetes, blood pressure, dyslipidemia, diet and exercise, there is a reduction in mortality by 45%. and at the age of almost 21-year follow-up, and this is a study called Steno-2 study, we started in 2002, and now this is a publication from 2016. So we know in a diabetic patients, if you can control these multiple risk factors, then there are definite reduction in heart events. And a good anti-diabetic. So GLP-1 as an anti-diabetic has 4 important properties which none of other drugs have. One, it is only anti-diabetic which or insulin secreting agent which doesn't cause hypoglycemia because it is insulin glucose dependent insulin secretion. It's an anti-diabetic which inhibits glucagon, and third thing, it acts on the brain and as well as the GI motility. So these are the 4 important characteristics. So it has good glycemic control, reduction in body weight. So when we speak of lira and injectable SEMA, the weight reduction of liraglutide is something like Saxenda is 6% to 8%. However, with injectable SEMA is almost 15%. And when you see caloric intake reduction or loss of caloric intake with liraglutide, if it is 6 to say 15%, it is almost 30 to 40%. And we have already seen Dr. Chokhalingam, how does caloric intake or reduction has changed the outcome of his heart failure as well as HFpEF patients, though currently this drug is not indicated for those type of patients. But definitely weight reduction is important in those patients. So GLP-1 analog is one of the ideal anti-diabetic drug, and we are lucky that the SEMA, the most potent injectable GLP-1 analog, is available with us now within an oral form. It's the most of the potent human GLP-1 analog. So for patients, people who have used injectable in USA, for them probably this is not a new drug. This is just an, what I will say, an old wine in a new packing, and you have seen all pharmacokinetics, how once a day it achieves serum level as a dose of what we call is an Ozempic or an anti-diabetic dose. So currently you have seen that oral semaglutide has reached the first step of the story of GLP-1 analog, and as the story unfolds in future, we may see the CVOT reduction, and maybe in future weight reduction, and in future trials in HFpEF, which is called obesity-related HFpEF, and we will see that obesity-related HFpEF as a reversible cardiomyopathy. So the final few slides about the potential mechanism, how do GLP-1 RA are affecting this atherosclerosis and reducing CV risk. So this is HbA1c, and this is the oral semaglutide pioneer program, the most potent with 14 milligram and HbA1c reduction of 1.5, which is not seen with any of the oral drugs except maybe injectable insulin, and it is consistent with what we say is an injectable form of Ozempic. The oral is also performing. We expect same because the pharmacokinetic level, drug level with oral is similar. So, and if you have an HbA1c to start with more high, like more than 9, then you get HbA1c reduction as good as 2.5%. Second is blood pressure, the body weight. As I have already spoken, a good body weight, step 1, step 2 to step 6 to step 8, there are various clinical trials of injectable semaglutide, which shows this weight reduction. And now this anti-diabetic dose of oral semaglutide has shown weight reduction across these all pioneer program of almost 5 kg. So when we use injectable, with our past experience with this GLP, when we use liraglutide, and you see that liraglutide can reduce 5-7 kg weight, but 50 unit insulin goes down after 3 to 4 months, and we have seen almost 30 to 40 kg weight reduction in people with weight something like 120 kilogram. So by reducing insulin requirement, and also there is an additional weight reduction in what we say is real life experience. Then reduction is waist circumference. You lose the what you say is the fat mass and no effect on lean body mass. So HbA1c, body weight reduction, a minor effect on a blood pressure. In all pioneer program, there is 2 to 4 millimeter mercury or 1 to 6 millimeter mercury reduction, and we know the benefit of blood pressure reduction in cardiovascular system. Then we have lipid. We have already had a talk about LDL reduction and all. This drug doesn't have a major effect on lipid, a minor trend. It is not statistically significant. We'll say 4% reduction in LDL and 15% with reduction in triglyceride. But if the patient has a good weight loss and caloric intake, we can see a larger reduction in TG. Then the last is inflammation. You saw in Dr. Hajra's slides, so inflammation is a large residual risk. We have tried lot of drugs, whether in acute coronary syndrome, chronic coronary syndrome. We have used methotrexate, colchicine, and n number of drugs. And even I am aware of a CANTOS trial where interleukin-1 antibody was used, and Paul Ridker in last 2 decades is trying to get over this inflammation in our clinical practice. But it has never been successful because there is a very thin line between what we call inflammation and infection, and patients are getting infection more. So this drug has an advantage. You have seen gut immunity, gut inflammation reduction, and one of the marker what you can see is C-reactive protein. It goes down and much more than EMPA, which doesn't has this effect. So this drug basically, when given to our patient, you can see when Ribelsus slowly stepped up from 3 to 7 to 14 milligram, you can see the changes in HbA1c, weight reduction, better blood pressure control, and this is something like a steno trial. So Dr. Anand Chokalingam told that, he gets this patient done every effort, but we know our patients are not going to do this fasting, and this is something like a fasting mimicry. By reducing caloric intake and even what you say, it reduces leptin resistance. So definitely these are the all benefits for our patients, and his Q1 risk score has come down to 34% by this risk reduction. So now the GLP-1 analog, which was in advanced and more complicated diabetic, and as with oral semaglutide, the scope is definitely increased as it's more acceptable. CV risk reduction by semaglutide is direct and indirect effect, and by modulating the CV risk factor like lipids, HSCRP, blood pressure, it has anti-atherosclerotic benefit. And this clinical evidence, they are suggest that the anti-inflammatory is also one of the relevant modulator of oral semaglutide. Actually, it is practically all of this GLP-1 RA. Thank you.